happening there, which is the patient who has owned up to their condition, they have disclosed, they have embraced that they are living with HIV, they are empowered and activated, to take responsibility for their own health, which I think is something as well which is missing. And in today's world, we really want to minimize. Actually, if we had it our way, patients wouldn't be visiting facilities at all, unless if they are sick. We don't like the idea of stable, healthy people visiting a hospital or a clinic, So if someone can come once a year, even better. I'm hoping at some point patients will come and check us every 5 years because they've taken responsibility for their own care. And we have found other ways of delivering drugs to them closest to where they work, their homes, their churches, and they are stable enough to care for themselves unless if they are not well. So these differentiated models of care, the support and many other ways to deliver treatment are very, very crucial. Right. So I hope you understand that this is the slide. Anything that comes after here is just a bonus, ne? All right, colleagues. So yes. Before you start ARVs, it's important that you assess your patient. Like I think I've spoken to this already. Patients need to be prepared to start ARVs. We should never take it for granted. There is a lot of psychosocial challenges that our patients are experiencing. We need to help them on how they can win, even if the environment is not conducive. We need to identify and treat opportunistic infections and also screen for some of the things that we know that they are leading causes of death in people living with HIV, especially TB and cryptococcus. Very, very, very important infections, especially because once you screen your patients, you can actually prevent the occurrence of these conditions like PCP, PJP, pneumonia. Baseline tests generally at the basic level, you need to know the kidney function of your patient. You need to know their baseline CD4 count because the CD4 count is a gateway for some of these interventions. If you don't do a CD4 count, you won't know which patient can benefit from fluconazole preventative treatment, as an example, if she's pregnant, it means now it's urgent. There's a passenger as well whom we want to ensure that they are born HIV free, so that they can really have freedom. And don't forget to stage your patient, because when you stage, it gives us the confidence that you have asked the right questions, you have touched your patient and examined them, and you have screened for opportunistic infections. And the staging helps you to see as well whether you are dealing with a stable patient or a patient who is at risk of dying if we do not intervene appropriately. These three here are the key prophylaxis therapies. Please, just issue them to those who are eligible. Don't hold them, and keep them in your lockers there. C is for cotrimoxazole prophylaxis therapy, which prevents PJP pneumonia, toxoplasmosis, some of the diarrheas, there, microsporidium, even malaria, prophylaxis. So cotrimoxazole prophylaxis is a really cheap, life-saving intervention. This ITPT used to be INH prophylaxis therapy, but now we have more options beyond isoniazid. You can use 3-HP, you can use rifampicin and INH. So now we call them TB preventative treatments. So you must screen your patients. And don't forget, in the HIV world, we do not just screen with questions. You still ask the questions. Are you gaining weight? Are you losing weight? Are you having night sweats? Loss of appetite? Are you coughing? But those questions do not exclude that this patient might still have TB. So we screen by collecting sputum, and this sputum must be sent for a gene expert or a TB NAT, which is a molecular test, right? So that is very, very important. Then consider if your patient is eligible for fluconazole prophylaxis therapies. In the public sector guidelines at this point, we still use a CD4 count less than 100 for a crack antigen test to be done, which if positive, you must start high-dose fluconazole and refer your patient for a lumbar puncture. I must say the guidelines are about to change such that this test can be done even when the CD4 count would be above 200 cells. So very important. So you must then make sure your patient is now ART readiness, colleagues. It has never, it has never been just about clinical assessment, right? Even if I'm healthy, I'm well, there's the psychological aspects of it. Don't give me treatment if I'm not willing to take it. You have to really ask me, are you ready? Do you want to take the treatment? And I need to have a fair chance to commit to that. And there must be that adherence plan where you say, what does taking ARVs, what does it mean? So you're telling me as a patient, it means you must take your treatment every day. It means you must do your viral load at 3 months, It means you have a responsibility for your own health, But you also tell me the benefits of taking. You'll be back to your health. You'll be able to go back to work, Then we sign the contract, which is an adherence plan. It's an agreement. You also tell me that don't worry about transmitting HIV to your wife, Dr. Mawela. If you get suppressed in the next 3 months, never worry again. As long as you stay suppressed, you can never transmit HIV to your sexual partners. Whoa, once I hear that, I tell you, I test today, I start ARVs today, I keep them next to me, take them every single day. And also I go and disclose because now the fear of transmitting it to my sexual partners has been eliminated. That topic is coming, colleagues. We shall deal with it on these basic HIV topics. All right. Are we together? Okay, I never finish my talks there. So let's see if we can finish this one. Now, work is a process. Work is a process. Even initiating a patient is a process. You need to know what you are doing. You need to take proper history. It's part of the process. Examine, do your urine dipsticks. You do your urine LEM test if it's indicated. Have a problem list, educate your patient, but the initiation, the giving of the medication itself is a process. And I borrowed this slide. I can't remember who designed this framework. I've just updated it. And if the colleague is here, I acknowledge you, colleague. But these are the 4 critical steps. Number 1, determine the timing. Is this patient who's in front of you the right candidate to start today or not? Not all patients must start today. Most patients, 99.9, will probably start same day. But that 0.1 is very important that we do not start them same day. Step 2, once we have decided that, fine, I'm starting, is this a candidate for TLD1 or TLD2? Is this a patient who's treatment experienced and with previous treatment failure? We'll come back to that. Once you have chosen your regimen, what are the potential contraindications that you need to assess? And therefore, based on the drugs you have chosen, what baseline tests do you need to do? I mean, it's a 4-step process. Let's go through it. So the first step, determining the time frame for initiating. There is a group of patients you must fast check. If she refuses, get another person to counsel the patient. If she still refuses, get another health worker. If she's refusing, get the family to come on board because she is pregnant and we are worried about her health, but also the health of the unborn baby, whom we must give an opportunity to be born without HIV, right? And then stable HIV positive patients must be initiated simply because they are stable. There are no complications. We are not worried about them. They still look healthy. They are WHO stage 1, stage 2. They don't have any other conditions. Where you are dealing with a patient who's got advanced HIV disease, you can still start them same day, but it depends what else do they have. I mean, if it's a patient with a CD4 count of 2, they've got a headache, I mean, you are not going to start them same day. You have to investigate this headache and get clarity on what is causing the headache. You can still start them on Bactrim and many other things. Investigate the headache, do the crack antigens, exclude serious things, then start them when you are sure. Someone who's got TB and is on TB treatment, or you've just started them, try to see if they can complete at least 2 weeks of TB treatment first. before you consider starting them on ARVs. If they've got very bad infections like TB meningitis, cryptococcal meningitis, you have to wait about 4 to 6 weeks really before you can make that decision to start them on ARVs. Right. So timing is very, very important. But what makes us happy is that the majority of patients are generally eligible clinically. We're talking about clinical readiness to start the same day, right? And these are some, if you go to the HIV Clinician Society guidelines, I think they've put a very nice table clarifying what would be some of the reasons for you to delay ARVs and not start ARVs the same day. A patient where you suspect or you have diagnosed cryptococcal meningitis, TB meningitis, if it's just pure pulmonary TB, non-neurological, I mean, they need to take TB treatment for at least 2 weeks, then, reassess and then see if you can start them. A patient who does not have this, but they have headaches, or it's someone who has TB symptoms, as you assess them, forget the target that you have been given. Just, reassure the patient, investigate, exclude TB or confirm and treat, and patients who've got other things. I mean, there might be a patient who's got 4 of urine in their dipstick, they are older than 50 years, they're also diabetic. I mean, you might want to exclude that they have serious kidney disease or give them a renal-friendly regimen, which we will discuss shortly in terms of this, right? Don't forget, right, that a patient has to be ready. There's no point in dishing out ARVs if a person is going to store them somewhere at the boot of their car. It's important that you go through that process. And there's always 1 or 2 people in 1,000 who will say, I'm not ready. So if you're not ready, what do? Don't be angry and just come back. No, you still have a responsibility, which is what? You still do their baseline tests, You must keep them in your wellness program so that you can make proper follow-ups and you can even allocate more experienced counselors like your social worker, your psychologist, so that they can see what fears this patient have and they can see if there's additional support they need. Hopefully, we don't get to 6 months without ARVs, but if we get there, you might need to repeat some of your baseline tests like your CD4 count, but also if the CD4 count is very low, it's 2 or 20, I mean, then you really need to try and do some intensified, because you don't have a lot of time, but don't just neglect them and say he refused ARVs. Let's have a plan. Let's keep them well. I think I didn't add here, you can give them cotrimoxazole prophylaxis. You can give them your isoniazid prophylaxis. If the CD4 count is low and the crack antigen is positive, you can give them, some of them. So you can keep them well. You can assess vaccinations that you can do in the meantime. There's a lot that you can do. You can do a full exam and there's oral candida. You treat it because the more you treat your infections, you actually contribute to delaying the progression to an AIDS stage. So it's a full package, which I didn't cover here, but make sure that we do not neglect them. Okay, are we together with stage one? Step one, stage one, step one. There's no stage one, it's step one, right? So let's look at the second one. So once you have decided that, fine, this patient is ready, is stable, I'm starting them on ARVs, the next question is, who am I dealing with? Am I dealing with a patient who has never been on ARVs before, or I'm dealing with someone who had been on ARVs before? There is a history of failing an ART regimen, right? Some patients have not failed. I mean, you might find that it's a patient who had one high viral load on an efavirenz-based regimen, right? And during those days, we used to say you need 2 viral loads, 3 months, but science tells us that one high viral load on a very weak regimen where you are using your NNRTIs, there's like 95% of patients who already have high-level mutations against some of those drugs. This applies as well during transition. So you have a patient who's been taking tenofovir, emtricitabine, and efavirenz, and now you have to transition them to a TLD-based regimen. And at the date of transitioning, you do not have two high viral loads. The patient had one high viral load. Basically, you have no confirmation that they had failed. You should classify that patient as a TLD2 patient, right? So does the patient have a recent high viral load or a history of previously failing an ART regimen? If your answer is no, you are dealing with a TLD1 patient. TLD1 is a regimen. The same TLD, whether 2 or 1, is the same drugs, but the classification is important because your TLD2 patients have a significantly higher risk of failing, this regimen in the future. So we must classify these patients correctly. If the answer is yes, your patient has previously failed the regimen and they are well adherent on standard art, you can still give them a TLD2, but classify them to say it's a patient who has previously failed a regimen, right? If they say yes, but the patient is unwell, maybe they have high viral loads because they are suffering from side effects, there's some drug interaction, or they've been failing whatever regimen for more than 2 years, these kinds of issues, discuss them with someone who's very experienced in HIV. Just discuss them and see what advice you would get. Most likely, some of them you need to do a resistance test. Some of them you need to deal with whatever they're experiencing and get the best regimen they can have. But this question is very important because if you do not do it correctly, sometimes you might cause a little bit more harm than good. Now, that was step 2. So we are starting today. Maybe it's a TLD1 patient, a patient who has never been on ARVs before. They have never failed a regimen before. So the question is how do you then proceed from here? Okay, I'm seeing your questions. We'll see if I'll be able to get time. How far are we? Okay, we're already past 19 hours. Okay, let's fast track and see. So a regimen, an ART regimen is 3 drugs, but it is not just any 3 drugs. You have a backbone and you have your anchor drug. The backbone is always 2 NRTIs, what we call nucleoside reverse transcriptase inhibitors, right? We prefer TDF with either lamivudine or emtricitabine, right? So, some patients will be on abacavir. I think those within the days are numbered. It's not a drug we use that often, but it's always 2. When you choose TDF and lamivudine or abacavir with lamivudine, and so on. So when we say TLD, it will be tenofovir with lamivudine. Now, these are your 2 NRTIs, right? Now you must choose your 3rd drug, which we call an anchor drug. We prefer your integrase inhibitors. There's still an option to use your protease inhibitors or even your NNRTIs like efavirenz. We still have patients where we feel efavirenz is useful. So, but generally speaking, your first line TLD1, tenofovir, lamivudine with dolutegravir, right? But there are instances where some of these drugs, we probably still need to use them. And you can see, so the preferred first line ART regimen is TLD. Most patients will get this drug, right? The advantage is that you use it as a once daily drug. And they should always be, tenofovir should always be given with either lamivudine or emtricitabine. Your responsibility in step 4, once you have chosen this regimen as your preferred regimen, is to ensure that there are no contraindications, particularly to tenofovir or dolutegravir. Very important, right? Where you find that there is a contraindication to use of tenofovir, it might be an elderly patient whose weight is less than 50 kgs, the age is above 50 kgs. Those are patients who are likely to have very low creatinine clearances with a creatinine level above 100. Maybe you are thinking, okay, this one, we might push her to have more kidney problems. So maybe forget your TDF and then maybe replace it with abacavir, right? So where you cannot use TLD, you would use ALD, which is abacavir, lamivudine, and dolutegravir. All right, super. Now, the other challenge is sometimes you do have contraindications to dolutegravir. Generally, it's usually because of drug-drug interactions. It's rare that you have a patient where there is an absolute contraindication to dolutegravir. In the public sector, your options would be probably to use atazanavir with ritonavir, and there's a place as well for efavirenz if maybe even protease inhibitors cannot be used, especially where there's also TB in the picture. Efavirenz is very good in the context of rifampicin-related induction of the liver enzymes. So very important. But remember, every switch you make introduces new problems, right? Even abacavir is not, it is not an absolute drug. Some patients may get a hypersensitivity reaction. So every time you switch, you must educate the patient and say, this is a new drug. This is how you take it. These are the side effects. If this happens, you need to come and see me. Because you'll give them efavirenz, they start to have horrible dreams. Some of them become suicidal, there's psychosis, there's inattention or lack of concentration, difficulty sleeping, many things change. So every switch you do, even atazanavir, the patient may come back with yellow eyes, but they don't feel sick. But because you didn't tell them that you might have some jaundice or yellow eyes, now the poor patient is worried, they disengage on treatment. So those are some of the challenges we have. Remember, colleagues, on each of these, we could talk for an hour. That's why maybe when we launch the diploma, you must join. But for now, it's just the process for initiating, right? So again, when you cannot give DTG, atazanavir, ritonavir is an option, especially because now we have a fixed dose combination. Efavirenz is also an option. All right. So again, to summarize it, your preferred regimen is TLD1 for patients who have never failed any regimen, and it will be TLD. What was I trying to? I did this slide, I was typing. Yeah, so I was just trying to give you advice, the rationale, who gets basically TLD1 and what are some of the things where TDF cannot be used. You can use abacavir and then the alternate TLD2. It's a patient who's being started on a TLD-based regimen, but there is a history of failing other drugs, so it's still TLD, you can see, but these ones, you need to monitor them closely. Once the viral load goes up, you start to become a little bit more worried versus if a viral load goes up for a TLD1 patient, you just tell them, hey, you need to take your drugs. But here you're like, maybe, TLD3, again, remember TLD can be used as well as part of the third line ART regimen. Don't just give third line drugs. Try to consult either locally or nationally and get proper advice so that you do not mess up the future options. In HIV, we talk about rational sequencing. There's things that we do in trying to preserve the future options for our patients. All right. And Dr. Leon, whenever he's here, he always talks about these groups of patients. So today we are not getting into that, right? So again, don't forget, check your baseline tests, It's important that you think, does my patient have advanced HIV disease? How do you know? Do a CD4 count. If it's less than 200, your patient has advanced HIV disease. Therefore, cotrimoxazole, INH, consider crypto, and then also do a proper assessment. They might have other problems, shingles, ringworms, herpes, they could have MEC, they could have many problems, right? If your patient is taking tenofovir, you want to assess their creatinine and creatinine clearance. If the creatinine clearance is less than 50 mils per mil, you probably need to reconsider a TDF and consider an alternate, which is probably abacavir. If you don't have abacavir, that means you're going to have to probably consider zidovudine. That means that you must do the H-bead and the drug is twice a day. So really, we don't want to go that far. And I have good news as well. TEF is coming to the public sector. So these are patients who would then, some of them benefit from using, a better version of TDF. Think about TB, do your sputum for TB nut, or what we used to call gene expert. If the CD4 count is less than 200 and the patient also has TB symptoms, maybe a urine LAMP test is also useful in an outpatient basis. If they're admitted, do the urine lamp anyway. Think about crypto, and then do your crack antigen. If it's positive, you have to start high dose fluconazole, 1,200 milligrams. Refer your patient for a lumbar puncture. All right. So we have done the 4 steps, basically. I said, decide. Are you initiating today or later? If you are starting, is this a TLD1 or a TLD2 patient, right? If it's a TLD, what contraindications do you need to assess and exclude, and then and what baseline tests do you need to do? You have to do it. There might be more things you need to do, but this is like the minimum things that you need to really consider in terms of ART initiation, right? So common things, the issues now, we're getting into the issues which we deal with every day. And each of these is a topic. I mean, we had Dr. Jeremy Nell just really taking us through the evaluation of a patient on a TLD-based regimen who presents with a rising creatinine. It was a full topic. I only have one slide for you to say, when you have started TLD, and the creatinine levels are rising, you have 3 things to ask. Is the rise less than or more than 30 micromoles per mil? Is it less than, right? Did this particular rise occur within the first month of initiating a DTG-based regimen? I mean, if creatinine is rising after 1 year on TLD, there's probably other things going on, right? Maybe the rise did not progress after. So the creatinine went up, but when you repeated it in a month later, it did not progress. So if your answer is yes to these 3 questions, so there is a rise, but it's less than 30 micromoles per mil. It is happening, within the first month. And when you repeated it, it sort of flattened. It didn't continue to go up after 30 days. It's if the creatinine rise is less than 20, it's probably DTG related rather than TDF related. You probably need to leave your patient on the same regimen and continue monitoring your patient. If it is between 20 and 30, it's just, in the middle there, it's a patient where you really want to repeat your creatinine in 1 month's time, right? However, if the creatinine is rising and the rise is more than 30 micromoles per mil, it has happened beyond the first month and it's continuing to increase, you are probably dealing with something else. The patient could have had a pre-existing liver disease, which maybe we missed, or it is TDF related or other drugs that the patient is taking. So that this group of patient here needs further evaluation, right? So basically, if your patient is a yes, even at PHC, if you are a very experienced NIMAR nurse, you should be able to really counsel your patient, keep the patient on TLD, and then repeat the creatinine clearance again in 1 month's time. If in 1 month's time it continues to increase, and the clearance itself is deteriorating, and also maybe it's a patient who's got other pre-existing other pre-existing kidney disease, then it's a patient you need to discuss with your doctor and probably consider referring that patient up to be seen at one of your hospitals, depending on your referral pathways in your region. And remember now, what we are saying here is that you have a patient on TLD. And we know as you start TLD, the D part of that regimen may lead to some rise in the creatinine, which is non-pathological, right? Now, this framework is trying to help you to determine when can you say this rise is pathological versus non-pathological, right? If it is pathological, a little bit more needs to be done to evaluate your patient. And a renal-friendly ART regimen would be ALD, abacavir, lamivudine, and dolutegravir. So I hope we are together on that one. All right, so this is our process. I think I'm moving on from this one. So the other thing is reinitiating. So sometimes you are not initiating a new patient. You are initiating a patient who was previously on ARVs, but maybe has missed appointments, or what we call has disengaged from this particular treatment. So the first thing is, how long did the patient miss, their appointment? So they've missed the appointment, but they've returned in less than 28 days. The patient says, I'm well, and they're not on any serious opportunistic, infection treatments. What is our responsibility? Continue the same care, assess, if they are struggling with side effects, adherence, the things that you can control and make life a little bit easy. If they have difficulty getting to the facility, can you help them to take treatment closer to home, work, church, whatever is easy for them, and then address any challenges they have, and resolve it. If they have missed by more than a month, or it's an or, right? Or even if it's less than 28 days, but the patient is now a little bit sick, and they're also on other treatments for other opportunistic infection, this patient, you cannot just give ARVs and say, go home. You need to assess them. You need to ensure that if there's a new infection, it is treated. If they have advanced HIV disease, make sure that they are on the right prophylaxis therapies, unless there is an obvious indication, like maybe you have now newly diagnosed TB, which means maybe you want to delay ARVs a bit. If there's no obvious clinical indication to defer ART has to be started, and preferably it should be TLD. This group of patients, you might need to see them again in 2 weeks' time. But remember, the more visits you create, the more your patient is likely to disengage in care, because they can't afford to come and see us all the time. So make sure that if the frequency of the visits there's a requirement that the visits are frequent, try to make sure that it's really, really needed, because otherwise that intervention on its own may push your patients to disengage, and then make sure that you repeat the viral load 3 months after restarting your patient on ARVs. You don't have to do a viral load on the day when they come back. You must start them on ARVs first. You can't evaluate a viral load on a patient who's not on ART. All right. Are we together on disengagement? It's quite common. I mean, people have fatigue now, treatment fatigue. They stop, they come back, they stop, they come back. As they come back, you need to know how to evaluate your patient. All right. Hey, it's 20 past. Let's see. Okay, I won't say a lot of things about viral loads, except that the goal is to always get to a viral load of less than 50 copies. We do the first viral load when the patient has completed 3 months on ART. The guidelines talk about dispensing cycles. It's fine. It's language, it's English. We accept it. So the first viral load is 3 months on TLD, 10 months on TLD, and then every year. Anytime the virus shows its hand, you have to provide enhanced adherence counseling. You have to address whatever issues the patient has raised, whether they are forgetting, whether they've got an infection which needs to be treated, side effects, support them during these 3 months, get a treatment buddy at home to support them, disclosure, repeat the viral load in 3 months' time, and hopefully they are suppressed. If they're not suppressed, you need to monitor them a little bit closer from then onwards, right? I won't go too much on this slide. We will share the slides because it's a very busy slide from the DOH guidelines, but it talks about how you monitor, ARVs from a clinical response, immunological response, and some of the things you need to manage side effects and toxicities. I think the part that is sort of not really known is this part here, where they talk about patients with a CD4 count less than 200 cells. We need to repeat the CD4 count every 6 months until the CD4 count is above 200. Please pay attention to the small things in the guidelines which make a big impact on this group of patients, because these are patients who are very sick. We don't see a CD4 count of 2 and repeat it next year. That is not the guidelines. Again, look at the viral load. If during ART, the viral load increases to more than 1,000 copies, it must be you must repeat the CD4 count every 6 months until the viral load is less than 1,000 copies. So there's the things that are thin lines in the guidelines, but they are very impactful for the right patient. So that's very, very important that you note that a CD4 count is not just baseline in 12 months. There's a group of patients where we must do it every 6 months, right? Okay, but the other things I think you will read and figure themselves. Okay, so as I get, I think to the end, I'll probably have 2 or 3 more slides. DTG side effects. So the key message is generally they are rare and they are mild or self-limiting. So it's rare that we really interrupt DTG because of side effects. I mean, insomnia, it's at night, right? You just tell the patient to take their TLD in the morning. Headache is problematic, but most patients are able to get used to it, and then eventually their body adjusts and they don't have headaches anymore. But if it's persistent, do a proper evaluation. Yeah, like I've said, if insomnia, which is the biggest complaint generally speaking, ask the patient to take TLD in the morning. I won't go through a lot about DTG and weight gain. There's a session coming with Dr. Leon, I think it's next month, on the evaluation of weight gain for patients who are on ARVs. He will take you through a lot. The only thing I want to tell you, just to make sure that the message is clear, right? There is no specific direct sort of scientific evidence that DTG causes weight gain. Actually, all ARVs, if you have lost weight and you take any ART regimen, you are going to gain weight, right? In the studies where DTG was sort of thought to be associated with weight gain, those patients were taking other drugs that are generally associated with weight gain, let's say like TEF, for example. So it's very important that you understand that. And also, there are a group of patients whom, when we transition from an efavirenz-based regimen to a DTG-based regimen, these patients may gain weight. And the context under which this happens, these are patients who are known to be slow metabolizers of efavirenz. So they were on an efavirenz-based regimen. They were metabolizing this drug very slowly, so they had toxic levels in their system, which then led to them not gaining weight, right? So you're on an efavirenz-based regimen, you are not able to metabolize efavirenz optimally, you then have toxic levels, right, that contribute to a patient not gaining weight. So during transition, what happens? We say stop efavirenz, give all patients DTG. So what does that do? You are now removing the toxic drug, efavirenz, for this group of patients. This toxicity of efavirenz was sort of pushing them not to gain weight. Now it's no longer there. What do? They gain weight, right? So why are they gaining weight? Is it because of DTG? No, it's because you have removed the toxic drug. All right. So yeah, but like I said, the first week of September, we're going to be dealing with this topic with Dr. Leon, and I think you will get the detail around it. But I think I've sort of explained it to you in a rather simplified manner, that patients who are transitioned to DTG gain weight because we have removed the drug that was making them not to gain weight. Okay. All right, super. I think this one we have addressed. This we won't talk about, but I can say once the guideline communication around the introduction of TEF particularly has been announced, we will come back. And then the only thing we will tell you is that for patients who have low creatinine clearances, you can actually use TEF up to, a creatinine clearance of 10. So most of our patients will still be on TLD, except that the T won't be TDF, it will be TEF. But yeah, and also in the context of declining kidney function, make sure that the other drugs as well are adjusted. And if you go to the Clinician Society guidelines, you would find this nice table. You can see that abacavir is the main NRTI that is sort of safe in renal impairment. You still use the full dose. You don't need to do any renal dose adjustments. Lamivudine, you must adjust. Zidovudine at lower creatinine clearances, you must adjust. The other drugs we no longer use really. The bottom three are metabolized through the liver system. So when there's kidney impairment, you don't need to adjust anything. But in the near future, you'll be using TLD, but it will be TEF rather than TDF, especially for those with lower creatinine clearances. But the detail, let's wait. As soon as we have that memo, we will come back and explain what the drug is, how it works, and how you use it, especially because we are likely to have it as a fixed dose combination and not as a single drug. So you'll probably only be able to use it up to a creatinine clearance of about 30 or so. But yeah, coming soon, coming soon. Let's be patient. Don't forget as well on TLD. So TLD has 3 drugs, as you can see here, which are very effective in the management of HIV. But 2 of the 3 drugs, T and the L, they are also effective against hepatitis B. So it's very important that when you have HIV and hepatitis B co-infection, you pay attention and avoid unnecessary interruptions of your tenofovir there, right? Because if you interrupt TDF and you put abacavir there, you are now going to be treating hepatitis B as a monotherapy. Your patient might get a hepatitis B rebound or a very high viral load from hepatitis B, and they come back very sick with liver disease or a very bad hepatitis, right? But we hope that we won't have to be adjusting, the TDFs to what. We will have TEF. That means if there is renal issues and the patient also has hepatitis B and HIV, rather than just stopping TDF and giving abacavir, you would stop TDF and give TEF. Now, TEF and lamivudine are still quite effective against hepatitis B. But the best advice is to always consult where you have a patient who's got HIV and hepatitis B, but they also have renal issues. You're most likely going to be advised not to interrupt this regimen, maybe dose adjusted as per the kidney function. But hopefully at some point, TEF is there in the public sector and we no longer have big issues when we have kidney problems. Okay. So I think the last part is just to say drug-drug interactions. And what is the best advice about drug-drug interactions? Have a formulary. Go to www.hivdruginteractions.org checker, Liverpool HIV iChat is the best thing you can have. Otherwise, visit the hotline, the South African National Hotline, their website. They have a very nice app as well, or you call them and you get advice, right? However, with regards to TLD, we are always worried about rifampicin, which is a liver enzyme inducer because it has a negative impact on DTG. Therefore, we need to increase the dose of DTG. I know there are studies that show that there's a group of patients where you don't need to adjust, but our guidelines have not changed, particularly the national guidelines. The Clinician Society guidelines do give advice for stable patients with no previous treatment failure, what you can do. But in terms of the national guidelines, all patients who are on a rifampicin TB regimen, the DTG must be given 12 hourly and not daily. So basically, the patient takes their TLD, let's say they are taking it at night. So they take TLD at night, but in the morning, they need to take an additional 50 milligrams, right? Pay attention to supplements that patients are taking to boost their immune and stuff. Some of these, like calcium, bind to DTG, form complexes, and fast track the excretion of DTG so that it's not absorbed. So you always have to assess and really give your patient, the best advice. Anticonvulsants do the same thing as rifampicin. So you might need to, again, increase the dosing of your DTG if your patient is epileptic. DTG itself may increase metformin levels to sort of toxic levels. So the advice is not to exceed 8,000 milligrams in a day, 500 milligrams, 12 hourly, right? My advice to you is not to interrupt, diabetes medicines. I mean, it's a very you know, this thing has to be dealt with patient by patient, depending on where they are. You know, if you have a patient, who is controlled, maybe reduce the dose. For example, if someone is taking metformin, 500 milligrams TDS, let's say for argument's sake, you can actually reduce it to have a dose that basically means that under the influence of DTG, they'll probably have a similar drug levels and be able to control their sugar. But I do not recommend switching people to insulins because we want to give DTG, So you have to make a proper assessment for each patient. There's no single answer here, but the key thing is for us to not violate the guidelines and ensure that we do not have patients on DTG who are also taking metformin 858 hourly. I think rather you take it to BD, give them DTG and see if the sugar remains controlled, because DTG is going to increase what? The blood levels. So you reduce the dose a bit and see. If they are controlled, then you are fine. If they are not controlled, then maybe you need to look at other things. It's a bit complex than that. Ne? Again, TB and HIV drug interactions, your NRTIs are metabolized through the renal system. You don't need to do any dose adjustments. If your patient is on a DTG-based regimen, you need to increase the dose to 50 milligrams 12 hourly. If your patient is on efavirenz, there's nothing you need to do. Good. If your patient is on nevirapine, you should never give nevirapine with rifampicin, right? However, you shouldn't be having patients on nevirapine. Try to see if you can give them a TLD-based regimen. However, this situation here is there, especially for your neonates. Remember your neonates, those who are diagnosed HIV positive and they are less than 1 month of age, or their weight is less than 3 kgs, they are likely to be on abacavir, lamivudine, not abacavir, zidovudine, lamivudine, and nevirapine. So these ones, those neonates, call your pediatrician and you'll get an individualized advice. If your patient is on a lopinavir, ritonavir-based regimen, you have two options, which is either to double the dose if your patient is taking tablets. If the patient is taking your solution, then you have to give the standard dose and also add or prescribe additional ritonavir. All right. Atazanavir should not be administered with rifampicin. The same applies for our third line protease inhibitor, Juranavir. All right. Super. I think we are at the end. So yes, this is part of CCP's educational programs. I'm so happy that for a change, I've managed to finish my slides. Usually I just say, I will stop here. So I'm just happy that I've managed to get to the end. Let me share the link for membership and to thank you for really joining us this evening. And hopefully there is something that you have learned. Mathug, I've answered so many questions. Why did I become mute? Because I didn't press mute. Okay. So let's go through some of this quickly. So someone was saying is TB or crypto antigen, crack antigen test done regardless of the CD4 count? And I was saying we screen with GeneXpert in terms of TB for all HIV positive patients. And then your crack antigen is done at a CD4 count less than 100. It's about to be adjusted to be done at a higher CD4 count, right? On initiation of ARVs, do you start prophylaxis the same day? Yes, for your stable patients where you don't have any other issues, do start them on the same day. And it's mainly because we want to minimize them coming back in 7 days' time. We want to minimize visits as much as possible. So yes, your TB preventative treatment, cotrimoxazole, can be started same day. Previously, we used to say no. But actual practice, not science, has showed us that no, actually we don't have to worry. We can start them same day. What about hepatitis B? Yes. So your surface antigen test is part of your baseline assessments. Like I said, my talk was not comprehensive on all baseline tests that you might need to do, but just to show you how to approach the patient. And yes, please do your hepatitis surface antigen and document the results. And remember, anytime you are considering to interrupt TDF, check the hepatitis B status, right? For patients who have been on ARVs for more than a year and never used INH prophylaxis, can we still offer it to them? Yes. So there is a program where some districts are going through that, identifying them and offering them TPT. However, remember, the biggest impact of TB preventative treatment is on treatment start, right? Because most patients, after you have started them on ARVs, the first few months, that's when most of them would present with TB as part of IRIS. So try to start it early. That's very important, right? Zime, it's good to see you. I haven't heard from you in a while. You can't be emotional with such a patient. It leads them to shut down. Yeah, okay, Zime. I think I can't remember at 19 hours what I was talking about, but I'm sure it was about the psychosocial aspects of HIV disease. What happens to a pregnant patient who is not ready on ARVs? You have to be patient. You have to call the next person and the next person and the next person, get the husband involved and psychologists, social workers, to get an in-depth understanding of their fears, and then help them. Eventually, they understand and they would really laugh, but also help them to understand that they are not taking these drugs just for the baby. They need to take the drugs for their own health as well. Someone says, Ngoyi, Nkongolo, what is your opinion about the newly diagnosed HIV hospitalized patients who must be initiated if they start them on ARVs? But if it's non-neuro, if they don't have a neurological, let me tell you the conditions where you need to be very careful when you start ARVs. Patients who've got any neurological condition, tuberculoma, cryptococoma, toxoplasmosis, neurocystic psychosis, anything in the brain, you need to be cautious about starting ARVs too early. Number two, patients who have disseminated TB, TB pericarditis. I mean, I've seen a patient with cardiac tamponade after we started ARVs early. With Dr. Dave Spencer, at some point we started one, but we said we keep the patient in the ward. We're not sending them home. Kaposi sarcoma, patient has 2-3 lesions, you start them on ARVs, it gets worse. That's why you need to, as you start them on ARVs, make sure you have an appointment for chemotherapy. Children, you have a child who's wheezing, so he's got TB, and children generally have TB lymphadenitis in the lungs. The child is wheezing. What are you worried about? You start ARVs, those lymph nodes, they become big, the child can't breathe. So you have to contextualize it. Generally speaking, most patients can be initiated by the time you discharge them in the hospital. Teach them about IRIS, make sure there is support at home, and tell them what to do if the situation gets worse. But there are conditions where you need to treat the opportunistic infections first for a little bit longer, and then make sure that it's done safely. So I think Dr. Nkongolo, I think we have addressed that a little bit. Okay, evening, doc. Just to be slightly out of why do we still have different files for patients? No. So Teresa, we need to shift away from that. especially in hospitals, and try to integrate, TB and HIV and many other programs and have one file for all. But I think it's more around patient monitoring and issues of data management. So it needs to be done carefully. Those things are still there. Yes, they potentiate stigma, and we need to try and deal away with non-integrated systems, but we need to do them correctly. How do we treat newly diagnosed patient in labor at term? Number one, she's newly diagnosed. What is your interest? There is the baby. So you need to classify the mother baby pair as high risk, ensure that the baby gets high risk prophylaxis, which is zidovudine and verapamil as soon as the child is born. Make sure that you do a birth PCR or delivery PCR, as they call it, and ensure that the mother is started on ART as soon as labor is done. If it happens that she's newly diagnosed in labor and there's still time, you can actually provide TLD and verapamil as emergency interventions to minimize transmission to the child, but make sure that both the mother and the child are cared for properly. Super. Postnatally, the mother is not willing to start ARVs and is breastfeeding. So the rule, Regina, is simple in PMTCT. Never leave the infant unprotected. How do you protect the infant? There's only two ways. You either have the infant on prophylaxis or the mother on ART. So if the mother is not on ART or you long enough to be suppressed, the child must always be kept on prophylaxis, right? So that child will get zidovudine, nevirapine, the zidovudine for 6 weeks, nevirapine for 12 weeks. If at 12 weeks, the mother is still not yet on ARVs, you do not stop that prophylaxis. We should never leave the child unprotected. To protect the child, the mother must be on ARVs and fully suppressed, or the child must be on prophylaxis. We should never find a situation where the child is being breastfed, the child is not on prophylaxis, and the mother is not suppressed. Then we are putting the infant at risk. We will talk to PMTCT when we come back. Philip says, nice presentation. Thank you, Philip. I'm checking if we have time frame for CD4 count to become normal after treatment. Philip, hey, you must do the basic HIV course, because I think we covered this a bit to say, remember when you start ARVs, okay, colleagues, we have 3 more minutes. It seems like we won't go through all the Suzanne says, oh, Suzanne, I would. Our GP is lucky to have you make a turn at Northwest. Hey, are you still at RTC? Because ke tlo tla mara ka re o shiftile, Suzanne. All right, colleagues, it's so nice. I'm reading your comments. They are very inspiring. All right. Where were we? Okay, let's take 2 or 3 last questions and then we call it a 9. Now, the issue of okay, some of this, I wish we must do a proper workshop on HIV management. Remember, in terms of monitoring a patient, there's the clinical goal. The clinical goal is that your patient should not develop stage 3, stage 4 conditions when they are on ART. There is a viral load goal, which is the viral load must be suppressed. There is a CD4 count goal. So in an ideal world, you start a patient within a year, their CD4 count improves by about 80 cells, sort of, for most patients. Some don't get that far, But another goal about the CD4 count is once the patient is on ART, the CD4 count should never drop to the pre-treatment level. That is what we call immunological treatment failure, right? So it's a topic for another day, but I'm hoping that helps you as a snapshot answer. What should we do to patients who have been on ART and refuse to be switched to DTG? Don't force them. Let me tell you, have you ever had a patient, you stop efavirenz, they come back, they say, hey, put me back on that drug. My dreams are gone. I want my dreams back. Remember, There's people who enjoy the horrible dreams that you think is a side effect. Some patients are really enjoying those dreams. They're like, bring my dreams back. So don't force a patient. We don't have to force our patients, but we must educate, empower. The decision to switch is a shared decision. It's not our own personal decision. Because at the end of the day, the patient must take the treatment when you are not there, right? Okay. Okay, let's go. Okay, I think colleagues feel free to disengage from this session. I'm gonna continue with few more questions. And then if you are those who are still here, it's fine. If you are not here, don't feel bad. It's okay. Let's just go through a few more questions, ne? Just for us to try. So someone says, because it's anonymous, I have a female patient who once disengaged and landed in hospital and came back. When he came back, he was put on TLD1. Okay, disengaged TLD1. And then Craig was negative, CD4 count not improving, still less than 200 on Bactrim, clinically well, nothing to be done. Okay, few things. If your patient disengaged, but there's no history of treatment failure, remember, TLD2, or if the patient disengages and at the time of disengaging, they had a high viral load, you would say that patient is a TLD2 patient. So this one is still a TLD1 patient. So they are right. The issue of the CD4 count not improving, you have to evaluate your patient. Number one, you are saying here your patient is on Bactrim. You see, so maybe Bactrim is not a very good drug for your patient, but the challenge is the CD4 count is still less than 200. So you might need to evaluate whether you need to give Bactrim or not. And I'll do another talk on alternate drugs you can use. Dapsone, for example. There's other drugs you can use, which we will cover. Assess, other drugs that may be suppressing the bone marrow. Do your full blood count and see if your patient doesn't have a pen site. Because remember, if there's issues with the bone marrow, regardless of the ARVs, it's going to be very difficult for your CD4 count to recover fully. Other opportunistic infections as well. If the patient might have TB, might have parvovirus, so there's a number. If this is a PHC question, if you are the nurse, please talk to your clinical mentor, hopefully a doctor who loves advanced HIV disease, and they can help you to evaluate that patient very nicely. Doctor, may I ask, a patient initiated on TLD then comes with TB treatment 7 days later. Okay, the investigations done were not yet out due to this. What is the best approach? Okay, so you have started on TLD, and then the gene expert comes back 7 days later to say the patient has TB. Start TB treatment. Start TB treatment. If the patient is coping, you don't need to interrupt. Then adjust your TLD, add the additional DTG. Talk to your patient, support your patient, ask the patient to come back in a week or two and see how they are doing. Most patients, by just starting TB treatment whilst they're on TLD, they improve, they gain weight, they are more happier, and they are okay. Remember, iris is a possibility. So also tell the patient that things may go a little bit worse before they get better. Okay. Okay. It's 52 minutes, so let's take the last two. Ne? Last two colleagues, thumbs up if you agree. The last two questions. Okay, Dr. Then Juma says, what is the ideal frequency of viral load tests for a patient on ARVs? You said 3 months, but some programs say 6 months. Okay, so many programs in the world, but the standard in today's world, the ultimate standard, if you check the US guidelines, many guidelines, and you check the South African guidelines, we carry the biggest HIV burden, right? Is 3 months. So you do your first viral load at 3 months on ARVs. If it's suppressed, 10 months on ARVs. If it's suppressed, every year from there. But anytime the viral load is above 50 copies per mil, you have to provide enhanced adherence counseling. Try to resolve issues that your patient is struggling with. Support the patient, see them a little bit more frequent, provide a community-based support structure, a family member they've disclosed to help them to remember to take their drugs, then repeat it in 3 months' time, and then make the call. Okay, Lady M. D'Souza, let me tell you, you're asking about iris. Let me tell you, Prof. Menchis is coming back. in October, and he's going to talk about iris. And trust me, there's no better expert in South Africa, and as far as I know, in the world on iris than him. He has done all sorts of research on iris. I learned iris from him, but basically iris is not the one that's in the eye, colleagues. We know your eye has an iris, but this one is an exaggerated inflammatory response that your patient gets after starting ARVs, right? Yours is to classify your patient, whether this is unmasking iris, that means there is a hidden infection that you need to diagnose, or it's a paradoxical iris, that means there is a known infection, the patient is on treatment, but after starting ARVs, the patient is deteriorating. So you have to evaluate, is this poor adherence? Is this side effect? You have to exclude, is this another infection? And then eventually you reassure the patient, you consider giving your patient anti-inflammatory drugs, Brufen, Indosit, Voltaren, sometimes steroids, it depends, but there's a big topic on this coming in October. So be patient and you'll learn a lot. Just don't miss it. He's a very great professor. Okay, the last question for the night, apologies. Many patients on ART complain of heartburn. Please advise how to manage them to avoid interactions with, okay, firstly, it's non-drug treatments are probably the most valuable. What type of food is causing them to have heartburn? Avoid that, those kinds of things. And then if they have to take things like a myogel or whatever they're taking, you need to assess, does this thing have calcium? Does this thing have aluminum? Then you have to advise them on the timing. The best timing is always to take anything 2 hours before you take the drug, or if you have taken TLD, maybe take that thing 6 hours later, and I think that advice is included in the slides. All right, colleagues, that is it for today. It was a marathon. Sometimes I had to sort of try and chair the meeting and respond to your questions. But what can really make me happy, one, is that you have learned something positive from today's talk, and that you have something to tell your colleagues tomorrow when you go back to work. We will share the slides. I'm going to try. Usually we share, on the WhatsApp groups and the communities. Just try to join the communities and follow us on Facebook so that you can get even the replay. You can listen to this slowly. I'm sorry that we couldn't answer all the questions. I must say my sincere apologies, but I hope that you understand. Don't forget, Saturday, we have the internal medicine, and it's part of this, all these tests we've been talking about today, you need to be able to interpret them and nicely. May I wish everyone a peaceful evening with your families. And if we don't see each other tomorrow, have a restful weekend together. Yes, Orabile, super. Nice, guys. Bye-bye.